We have two speakers for this session. I will introduce them both right now. Dr. Joe Cameron is the critical care pharmacist, infectious disease specialist at the University of Missouri Healthcare. Dr. Cameron created the Antimicrobial Stewardship Program at the University of Missouri Hospital a few years ago, currently serves as the chair and rounds with the infectious disease team on a regular basis. He's presented frequently on the subject of AS to colleagues and infection prevention specialists. He received his Doctor of Pharmacy degree from the University of Missouri, Kansas City, and completed a residency in pharmacy practice at the University of Missouri, Columbia. As a member of the Infectious Diseases Society of America, he serves on a 16-member group to write questions for the fellowship exam. His colleague presenter this morning is Dr. Christelle Ilboudo, an assistant professor of clinical child health, Division of Infectious Diseases, University of Missouri School of Medicine. In this position, Dr. Ilboudo serves on numerous committees, including the Infection Control Committee and the AS Committee. She's published articles, a book chapter, and presented posters and invited lectures on the subject of ID. She also has been involved in research studies and grants. She received her medical degree from the University of Nebraska Medical Center in Omaha. After graduation, she completed a residency in pediatrics at the St. Louis University Cardinal Glennon Children's Medical Center and a pediatric infectious disease fellowship at the University of Missouri. Please help me welcome Dr. Joe Cameron and Dr. Christelle Ilboudo.
Thank you, Shirley. Greetings, everyone. Thank you very much for coming out to the presentation. As was stated, my name is Joe, and I'm the ID pharmacist that works at University of Missouri Healthcare. The disclosures that I have is that I am a professional speaker for both Merck as well as Allergan on 3 different antimicrobial agents, and that really doesn't fall much into this parameters, but it is my disclosure. For those of you that aren't familiar with the University of Missouri healthcare system, we are a 361-bed teaching institution. We are the only level 1 trauma center in mid-Missouri. We do have many intensive care units, as you can see from the bottom point, as well as surgical and burn ICUs, as well as the Missouri Orthopedic Institute and Missouri Psychiatric Center. So University of Missouri, being a mid-sized hospital, 361 beds is what we are registered for at this point in time. So I'm here today because I started the stewardship program. The stewardship program that I started, I will go through some of the timelines associated with it, but one of the questions that I get on a regular basis is, how did you do it? How did you start? Where did you begin? How have you gotten to where you are at this point in time? So one of the things that we actually looked at was, the article that came out approximately 7-8 years ago through the SHEA IDSA guidelines talking about an antimicrobial stewardship. And now we have the benefit of having the Joint Commission give us other mandates and other requirements that we are supposed to meet. Arjun talked about a lot of these earlier, so I'm not going to go that much in depth to them because it's just rehashing information that you all are perfectly well aware of, and you'll have the opportunity to see it in probably everybody's slide presentation because this is what's driving it at this point in time. As we had talked about the different areas, so not only are we looking at teaching institutions, but we're looking at nursing homes, we're looking at critical access hospitals. There are requirements that are actually mandated by the Joint Commission as part of the medication management section through the Joint Commission. There are 8 required medication management on 0.9 that we are trying to implement and that need to be implemented per the Joint Commission, CMS, and pretty soon the CDC guidelines. One of the things that I've tried to highlight within my presentation is what has University of Missouri Healthcare done to feel that we have met the requirements that the Joint Commission has set forward for us. So the first one is the action that's taken. So the first one right off the bat is to get approval from your C-suite that you can have an antimicrobial stewardship program. Dr. Stephen Witt and myself approached the Executive Council of the Medical Staff in 2008 to try and determine whether or not we should do an antimicrobial stewardship program. This was after the 2007-2008 paper that came out that basically identified specific actions that should be taken, as well as specific requirements that a pharmacy or a hospital institution should actually go through. It was approved by the Executive Council of the medical staff, and we were asked to move forward. The way that we moved forward was through a process leadership development improvement program. So PILDP, for those of you that are part of Missouri Healthcare. If you're not, then that's what it stands for. The PILDP program, we actually had physicians as well as nurses as well as pharmacists who went together and actually got through and troubleshot every single aspect that we could try and determine what we could do to make the antimicrobial stewardship work. We did the fishbone diagrams, we did the pathways, we did all of those wonderful things that everybody loves to do in trying to make sure that a process comes off and is pulled off. In 2009, we actually kicked it off, and we kicked it off within the intensive care units. At that point in time, we had a medical, a cardiac, and a surgical intensive care unit, and we focused on those 3 ICU units to start. In looking at the original papers that came out about antimicrobial stewardship, they said it can be location-based, it can be organism-based, it can be patient-specific. We went with the location aspect because we were working with our electronic medical record to actually identify and pull different antibiotics that were being prescribed to the patients within those 3 units. Since it was just me at that point in time, I had to go through all 3 ICUs at 18 beds apiece to determine whether or not the antimicrobial therapy was good. As you can imagine, the documentation that I would put on my documentation sheets was quite extensive, almost to the point where I felt like I was rounding on 60 patients by myself every single day, making sure that things were done. That became kind of tedious, and as we expanded to 2 more intensive care units, it became almost impossible to go through 90 to 115 patients on a daily basis. So therefore, we actually worked in tweaking it, and I'll take you through the steps at how it's kind of evolved over the last 6 to 7 years. At this point in time, we do monitor 29 antimicrobial agents for everyone in the hospital. So we're including the internal medicine, family medicine floors, as well as the intensive care units, and it's something that I do get a report on every single day. One of the biggest things about starting an antimicrobial stewardship program is making sure that you have key contributors from all across the institution. You know, I was fortunate enough to have the medical ICU director of Stephen Witt at that point in time, who's now the chief medical officer, and Dr. Witt has done a lot to not only further my education, but to help me become successful in the program. But at the same time, I've included other clinical pharmacists. I've included the infectious disease teams from both University of Missouri Hospital as well as Women's and Children's Hospital, being Dr. Ilboudo from Women's and Children's, as well as Dr. Cooperstock prior to her. And then I've also included attendings from different services. One of the key aspects that's actually helped garner success for the University of Missouri system is the fact that I have the authority to contact the attending physician to start with. As a clinical pharmacist, most of the time they talk to you to take the lowest level and then work your way up. After about 4 or 5 telephone calls, the simple answer that you get the majority of the time is, that's what my attending wants. Great. As an antimicrobial stewardship pharmacist, I need to have that conversation with the attending physician to determine whether or not why XYZ is being used, and can we find a better option, or is this the appropriate option? I got the approval through the Executive Council that I can directly contact the attending physician to have that conversation, and that cuts down a lot of the time that I have. But as you can see from the extensive list, not only do I have physicians, pharmacists, we also have infection control. We actually have the microbiology lab. We do have someone from our Cerner IT services if we need to call on them to help us build things. But the Antimicrobial Stewardship Program was built with a large number of individuals who have expertise in different areas. So when I started this program, it was a lot to take care of. I'm actually coming in front of a group and saying, hi, my name's Joe, and I'm a pharmacist, and I don't know if I like your antibiotic choices. What can we do about that? So that's not taken very lightly. What do you mean you don't like my choices? I'm a physician. You're a pharmacist. So what are we going to do with this? So many of the things that I started very low. I started with the more simple things to actually work in trying to gain not only my exposure to the attending physicians, more exposure to the residents, but to actually get out there and have some credibility associated with it. So we started the protocols. So cost savings is a huge aspect with Antimicrobial Stewardship Program, and most of the C-suite is going to say, how much money can you save me? So one of the adages that I've always kind of held tight with antimicrobial use is that antibiotics aren't going to go away. You may be able to curb or steer away from specific antimicrobial agents, but patients come to the hospital, they're going to need antibiotics. The way that I picture it's a balloon. If I have a balloon and I squeeze one aspect, another part's going to pop out. If I try and contain that one, another part's going to pop out. It's a never-ending battle, especially when you deal with the financial aspect. So there are many studies that actually say that over 4 to 5 years, you've probably experienced the most cost savings that you're going to have through an antimicrobial stewardship program. What is the C-suite going to say at that point in time? The stewardship program has not really saved us a lot of money. Is it a program that we need to continue to move forward with? And I think the overwhelming answer, not only from my job satisfaction and job stance as the ID guy, but also the literature says that when an antimicrobial stewardship goes away, those prescribing patterns fall back to using the more expensive, high-dollar, high-risk items. Which brings us to another elemental aspect. Is cost savings the main reason that we have an antimicrobial stewardship program? I like to say that it's a cost containment issue. I'm trying to make sure that we don't start everybody on the brand new, high-dollar, expensive items when our vancomycin, cefazolin, ciprofloxacin, Levaquin still work. Those are wonderful generic drugs that still work for the organisms that they are designed to treat. Looking at the antibiogram. I will show it later in my presentation about the antibiogram, but if the antimicrobial stewardship is there to protect the bugs from becoming so super resistant that everybody is on the newer cephalosporins, on colistin on a regular and consistent basis, our stewardship program is not being optimized and we're not doing it as well as we can. So one of the things that I started first was the IV to PO protocol, the conversion. I started, most information is actually out there that after 24 to 48 hours, you can actually, the pharmacy can go ahead and make the change from an IV to a PO medication, whether it's fluconazole, whether it's Levaquin. One of the things that I started of is I gave ourselves, as an institution, an extra 24 hours, so 48 to 72 hours. Most of the time, we do have the ability to convert those IV to PO, but one of the things that I found out is that if I reach out to the nurse and say, Nurse Ilboudo, is it okay if I switch Mr. Cameron from this to that? Is he taking things by mouth? Is he having any issues? Her answer is yes, I'm done, it's taken care of. If I need to reach out to the physician, I'd like to change this person from IV to PO. Do you have any issues with that? No. It's a 30-second telephone call that actually does a lot to benefit the patients. It does cost time. That time is very valuable for the people who practice in healthcare. But at the same time, getting that confirmation makes them going back and changing things and then coming back with, why does pharmacy have the right to change my patient's therapy? I'm the physician. That extra 5 minutes, or 30 seconds, sorry, can actually save a lot of that. And a lot of it is about the open communication. The guidelines that we have stated through the IV to PO protocol have undergone 2 revisions since we started it in 2008. It is more defined, it is more clinical, and it's one of the policies that's been upheld through the Executive Council of the Medical Staff as well as the Pharmacy and Therapeutics Committee. We don't have any issues in dealing with IV to PO conversions from most of our physicians. This is the list of medications that we have the ability to go IV to PO conversion. IV Tylenol is probably the hardest one, but most people have gotten it off their formulary at this point in time. The next thing that I wanted to do is, there's nothing worse than being in a department and I'm going to contact Dr. Ilboudo and say, Dr. Ilboudo, I would like to change the dosing of how you're giving meropenem. And her response back to me is, I talked to somebody else within your department and they recommended this dosing. So now I have conflict between pharmacists that work in the same department in dealing with the appropriate dosing for said medication that we're dealing with. So one of the things that I did is I wanted to make sure that the pharmacists were all on the same page. I put together dosing cards, dosing information based on the literature, based on what I found out there, to actually take through and look at the appropriate dosing. For example, if you look at cefepime, which is on shortage, but at the same time, cefepime can have any multitude of dosings, from 500 milligrams Q8 all the way up to 2 grams Q8. If I have different dosing recommendations that are coming from the pharmacy group as a whole, is that the best thing for it? So by having a stated guidelines as to what all pharmacists should be using for their dosing, it helps some cohesiveness within the department, as well as doesn't confuse the physicians when you're looking and making recommendations that the physicians are receiving. So this was something that I put together fairly early, and I've actually gone a couple of revisions. The majority of revisions that I go through is the difference between ideal and adjusted or actual dosing weight for the patients that we deal with. The colistin dosing. So the colistin dosing, most papers at this point in time say with decreased renal function, you need to load the patient. As an institution, if that's what we've decided to go with, that needs to be reflected on the card. And the other modality that has changed is our dialysis modality. We have 3 different forms of dialysis that we do at University Hospital, being a 4-hour, an 8-hour, 8 to 12-hour, or a 24-hour dialysis modality. Antibiotics are cleared by dialysis machines, sometimes differently, most times differently. So therefore, having a concise recommendation for patients who are on dialysis regimens, that helps the department to actually save face and look as a cohesive model. Other things that we did and that have progressed from level 1 to where we are at this point in time is to optimize dosing strategies. We've looked at continuous infusion, we've looked at extended infusion, and then we actually have a dosing service like many institutions do. Our dosing service will take care of the aminoglycosides, so your gentamicin, your tobramycin, and your amikacin. And then we also do vancomycin. We have nomograms that we follow for all of those 4 antimicrobial agents, and then we monitor and track and see how we do as a whole, as a system, as to whether or not we meet the targeted criteria associated with it. But one of the biggest changes that I made in starting the Antimicrobial Stewardship Program are the extended infusions as well as the continuous infusions. The continuous infusions that we have are going to be nafcillin and penicillin, and we give these antimicrobial agents over a 24-hour period. There is very limited data as to what the appropriate dose is in looking at continuous infusion. So for penicillin, we give 24 million units over a 24-hour period. For nafcillin, we give 12 grams over a 24-hour period. I would like to do studies to actually look at can we reduce the total daily dose that we are giving to 20 million units and 10 grams. I do know that there are institutions that do that for their patients. But it all goes back to the premise of why do we do continuous infusions? So both of these antibiotics or antimicrobial agents are beta-lactams. Beta-lactams work time above MIC. So if you have drug concentration over your minimum inhibitory concentration or the effective dose for bacterial killing, if you have a continuous time above the MIC, theoretically, it actually may benefit the patient. So the hard part is proving this. So in looking at continuous and extended infusions, I've got all the Monte Carlo data that I need. For those of you who don't know what Monte Carlo data is, it's best been described to me as a PharmD with a computer. So we're looking at drug concentrations in a theoretical model, and that's what a Monte Carlo simulation is. It's a computer basis. It's a computer-generated report. How does that interact or to transgress or to patients? At this point in time, it has been determined that it's not harmful. We don't know how much better it is, and it may be better in specific patient populations. So it may be better in the critically ill patient populations, the ones that have vast volume of distribution variables. So you have so much drug that's getting whisked away to where it's not supposed to be versus staying concentrated where it needs to be. So some of the things that we've looked at, with those reportings is we do a continuous infusion. Some home infusion companies like it, some don't, some pay for it, some don't. It's one of the aspects that we do in treating our patients within the house. The next is the extended infusion model. So the extended infusion model is looked at both meropenem and piperacillin tazobactam. There are institutions that use cefepime. At University Hospital at this point in time, cefepime is not one of our major players. Our 2 major players are going to be piperacillin tazobactam as well as meropenem. There were initial reports that came out looking at pip-tazo as well as meropenem as using it as extended infusion. You can see from the graph on the right, and I realize that it's difficult to see this far away from the screen, is that the line that is farthest to the right, that is the extended infusion. That is having time above the MIC for a longer period of time. So many institutions have been questioned as to what their standard dose is with piperacillin and tazobactam. So a standard dosing for a healthcare-associated infection for an ICU ventilator-associated pneumonia is 4.5 grams IV Q6. Okay, that is the standard dose agreed on by Micromedics, as well as the package insert, as well as Lexicomp for those different references. One of the things that we do at University Hospital is that we will load the patient. So we will give the patient 4.5 grams. Within 2 to 4 hours, we administer a continuous an extended infusion, and we use the 3.375 dose. The 3.375 dose is given every 8 hours, and it's given over a 4-hour time frame. How much literature is out there supporting that? There is some, but it's very limited. So being the antimicrobial stewardship guy, and dealing with infection control, and dealing with micro, am I causing harm? My dose is different than what the package insert says. I have limited scant literature that supports what I'm doing, but there are other institutions that are doing 4.5 grams as an extended infusion. So am I causing harm? And I will show that I'm not, but I will show the data that actually backs that up. This is something that we actually have, and apparently the formatting adjusted, so I apologize that this text box goes below. But this is one of the reminders that we actually have for extended infusion protocols. We have excluded specific patients from the extended infusion protocol, those patients being cystic fibrosis, as well as meningitis patients, because the meningitis patients frequently require higher doses. One of the things that I was taught very early in my pharmacy career, and I'm a pharmacist, is that drugs are bad, drugs are evil, drugs are poison. For those of you that know Dr. Witt, that is probably one of his biggest sayings. So I think that these are poisonous and bad and evil, but yet I'm in charge of making sure that they are appropriate. Okay, so one of the things that we've done with the extended infusion protocol is that we've actually dropped the poundage of antimicrobials that we're giving our patients in a 24-hour period. If we're giving them less poundage, we're not exposing them to as much toxicity as we are to the higher doses that are actually out there. But we don't want to give them so small of amount that it actually causes patient harm. Okay. So here we are in 2016. What is our program look like? What are we doing at this point in time? Well, I receive a daily report of every antimicrobial agent that every patient in the institution, being Women's and Children's, University Hospital, I receive a report every day. It's about 4.5 pages long. I have excluded specific antimicrobial agents. I've excluded cefazolin and I've excluded clindamycin because most frequently those are given as pre-op antibiotics. I do go through and I look at every patient that has, I now monitor 26 or 29, I think I've forgotten, antimicrobial agents on a daily basis. So if you have one of these, I need to make sure that it's appropriate. Vancomycin is another thing that I do follow, as well as aminoglycosides. With the dosing books, I'm not in charge of the dosing all by myself. The dosing book that I have is the floor book. So I will go through some of the patients on the floor, and I will help to follow and monitor the vancomycin as well as the aminoglycosides. I have 3 intensive care unit pharmacists that I work with side by side. Those 3 intensive care unit pharmacists have actually divided and broken their books out so that they have their specific patient population that they monitor and they follow and they draw levels on a regular and consistent basis. As I stated before, I have the ability to contact the attending physician. And when I do contact the attending physician, it's a very short conversation of, my name is Joe, you're treating patient X with X disease and Y antibiotics. Based on sensitivities that have come back or what has actually happened or transpired, I would recommend escalating, de-escalating, duration of action, whether or not they should get an ID consult, and then whether or not it's the appropriate empiric coverage. I have the ability at University Hospital to mandate an infectious disease consult. That being said, I have never made an actual ID consult go see an attending's patient without that attending's approval. It's one of those swords that I've kind of kept in my backpack because once I take it out, I can never put it back in. And most of the time that I do talk to the attending physicians, we do have the ability to work through it together as a team to help manage the patients in dealing with it. We also have documentation that I put in the medical record, and I will show you that momentarily. But if you look at the program design, this is taking from the new policy that we have implemented at University Hospital and as well as Women's and Children's, and there are minor differences between the two institutions. At Women's and Children's Hospital, Dr. Ilboudo will talk to you about what she has done and what she focuses on. With me being at University Hospital, most of the items that we go through and we follow up with, I try and do in an extremely timely fashion, which doesn't give me many days off, but at the same time, I'm dedicated to making sure that the stewardship program works. So in looking at the initial presentations and how they were come about, the initial publications, they talked about prospective feedback. They talked about retrospective. They talked about limiting formulary restriction, mandating ID consults. They talked about education. Many of those aspects, some we pick and choose from with being part at University Hospital. I do receive a 24-hour report that precedes the previous 24 hours as to what antibiotics are being dispensed in the institution. Excuse me. The other things that we look for is if a patient is started on amphotericin B, most of the staff is going to either send me a text message, they're going to call my cell, or they're going to page me and say, hey, I have an amphotericin B. Okay, so one, is the patient being seen by infectious disease? No? Okay, they probably should. Two, what are we treating? What do we know about the patient? And then I will go through and find out information that I can, and this is off hours. If it happens at 3 o'clock in the morning, my staff is not nice enough not to call me, and I sleep like the dead, so I probably wouldn't hear it anyway. But at the same time, I will be able to catch it first thing in the morning. So having one dose of an antimicrobial agent that we're monitoring is something that I'm okay with for those that aren't restricted, and we will talk about the restriction here momentarily. We essentially have carte blanche at University Hospital where the physicians have the ability to order whatever they want. I will go through within a 24 to 48 hour period and make comments as to whether or not it is appropriate, it is not appropriate, and whether or not it has infectious disease oversight. One of the baseline characteristics that I looked at when I first started this is many institutions say you have to have an infectious disease consult to have this medication given. Unfortunately, that has been shot down 3 times by the Executive Council of Medical Staff as well as the Pharmacy and Therapeutics Committee prior to about 2 years ago. One of the things that we would do is I would say, all right, if I have ID oversight, what is an appropriate percentage of ID oversight for the 26 antimicrobial agents that I look at? In my mind, I shot for 70%. So if I have greater than 70% of the targeted antimicrobial agents being monitored that is recommendation prescribed by the ID service or an ID board certified physician, I'm okay with it. Lately, the last audit that I did, it was approximately 83% that the specific agents that we were using were monitored and followed by infectious disease. The other agents, perfectly alternative choices. If you look at patients within the medical, surgical intensive care unit, the cardiac intensive care unit, if you have a severely septic patient, you pretty much try everything that you possibly can to help the patient. One of the last line therapies that is added within our institution, unfortunately, is micafungin. Should we add it earlier? Should we add it later? How much fungus do we really see? Micafungin is probably one of the ones that I do report on and have to contact the physician to say, where are we getting our fungus from? Where's the yeast infection? But at the same time, having greater than 80% of the antimicrobial agents that I monitor, followed by the ID service, I think is a bonus, not only for the prescribing patterns for our physicians, but as well as how much the ID exposure is actually focused on. Formulary restriction. Dr. Ilboudo will talk about different antimicrobial agents that are restricted at Women's and Children's. At this point in time, we have 4 antimicrobial therapy agents at University Hospital that are restricted only to ID, as well as making sure that I get a telephone call. Those 4 antimicrobial agents are the newer cephalosporin. We have a newer MRSA agent that's once a week therapy. We actually have an injectable antifungal drug and that is actually restricted. And we have an injectable influenza medication. All 4 of those medications need to have oversight by ID to make sure that it is appropriate for those patients, because I have mounds of literature that says that other less expensive alternatives are equally efficacious for those patients and for those disease states. Antimicrobial stewardship consultation. So this is an opportunity for the attending to say, you know what, I really don't want to do a full ID consult. I have a suggestion or a question that I would like to bounce off either Dr. Ilboudo or the clinical pharmacist that actually work in the ID role, being myself or the other 2 representatives at Women's and Children's. They give me a call. Hey, I've got this patient and I've got an MIC of 2. Is it okay to continue to use this antimicrobial agent, or do I need to switch to another one? I'm treating pneumonia. We just started the patient on it yesterday. They're on a narrow therapy, but it's sensitive. What do you think? The break point is at 16. I'm perfectly fine with where the patient is. You don't need to escalate or go to a more broad, larger gun antimicrobial agent. Okay, thanks very much. Not a problem. I just had that telephone call last week, but actually going and having the ability for the practitioners to bounce the questions off of an ID trained physician, pharmacist, nurse, that actually helps tremendously by having an antimicrobial stewardship consultation. Clinical practice guidelines. So the new guidelines actually state that you need to have clinical pathways associated with the patients that you're dealing with the patients that you're treating. I will show an example of one of the clinical pathways that I've put into place. I don't know how much it's used, but it's actually there as guidelines so that when we do have questions, we can refer the patients to that. And then education. Education right now is not as broad as what Dr. Ilboudo and I are hoping to achieve, but we do have grand rounds for some of our medicine, for some of our women's and children's, but we would like to include that more to newer hires and to other people to make sure that we meet more of the criteria that CMS has outlaid. Education, although, only goes so far. And if you have a set specified program that can provide the education, that's much better than relying on the attendings for the service. And if you deal with other institutions outside of an academic institution, you don't always have attendings that are going to be there to provide the education. This is an example of the progress note, and it's very short, it's very simple, it's very sweet. I discussed possible de-escalation with Dr. Witt. I discussed low concern for empiric coverage of MRSA and Pseudomonas. Why? Because the patient was on vancomycin. So anybody who comes from University Hospital, that's our residents' go-to, is vancomycin. Other institutions may use cefepime and vanc, meropenem, I hope not, and vanc, but those are what they go to at University Hospital. Dr. Witt agreed with de-escalation to unison 1.5 IV Q6. So therefore, I've now eliminated Pseudomonas as well as MRSA. The patient did much better. Thank you very much for allowing me to discuss this with you, me. And this is what I put in the pharmacy consultation service notes. So I do have documented interaction. I actually talked to who I talked to. I put down who I talked to, what my concerns and what my recommendations were, and whether or not it was accepted. Those are just some of the simple aspects that I've actually put within the electronic medical record. For protocol development, the easiest one that I was able to do was a Clostridium difficile protocol. It's very interpretive as to whether or not everybody should be using fidaxomicin. Once again, I'm a speaker for fidaxomicin. Don't use fidaxomicin first line. As to whether or not it's appropriate for metronidazole or for patients to receive vancomycin. What dose of vancomycin? At what point in time do you start vancomycin? And then if you do need to use your newer agents, or the ones that are listed in the guidelines, such as IVIG, tigecycline, rifaximin, fidaxomicin, where do those actually play within the guideline step-line pathway? And this is actually spelled it out, as well as the taper. Everybody hears about a vancomycin taper. There's one that's been probably published more than any. Here it is for you. All you have to do is click on the button, and the resident doesn't have to try and figure out what the taper is, and we get tapers all over the place. So this is an example of one of the protocols that I put within the electronic medical record. So monitoring. We had talked about whether or not the monitoring and how it's looked. As you can see, this is an antibiogram report. I've only selected specific bugs as well as specific drugs for the sake of this presentation. This one goes back to 2011. I have it way past farther than that, but 2011 to now. So we do it every 6 months, and we actually look at the information. I've condensed it from 2011 to 2016 to look at the first quarter. As you can see, for Acinetobacter, Pseudomonas, Klebsiella, E. coli, Staph aureus, as well as coag-negative staph, the antimicrobial stewardship seems to be doing effective work. If you look at the percentages on the far right column, for the most part, they've all gone up. That is what you want. You want to look at having positive results on your antibiogram so that your empiric coverage with the antimicrobial agents that you use actually is beneficial. You can see cefepime, meropenem, Cipro, piperacillin, tazobactam. So the different antimicrobial agents that were there, the percentages have gone up. If the goal of antimicrobial stewardship is to preserve the efficacy of our antimicrobial agents, this is a win, I guess, in my mind. We had talked about the extended infusion protocol as to whether or not by me dropping the dose from 3.375 or 500 milligrams of meropenem, has that caused damage? Has that caused harm? Are we hurting patients? Are our bugs becoming more resistant to those infectious, to those antimicrobial agents? This was a poster that we presented at University Hospital that looked at 6 years of data. One of the things that I started doing was looking at MIC drift. Now, as a pharmacist, I don't have a lot to do with it, so it really wasn't that difficult. But Patrick Smith, who is our microbiologist who is now retired, Martin helps as well, has actually gone through and helped identify and classify what the MICs are for our specific bug-drug combinations. I looked at 8 bug-drug combinations as to how it would look and whether or not we've had an increase in MICs associated with that. So we will have an MIC increase if we're causing harm with our antimicrobial agents. This breakout graph shows that we don't have an increased problem associated with it from the time that we started the extended infusions to where we are at this point in time. So in my mind, we are not causing harm with our extended infusion. We're giving less drug to the patient, but the patients and the bugs are staying the same. So we are not causing harm at this point in time. The other thing that this helps us to identify is to whether or not there's a glitch or a hiccup. So we did have a glitch or a hiccup approximately 3 years ago where we had an increased resistance to meropenem and I believe Pseudomonas. One of the things that I did is I identified all the patients that had really drug-resistant strains. Are those homegrown? Are those patients that have never been exposed to any other healthcare setting other than University Hospital? Are we causing and creating resistance? What we found out is that the majority of those patients were all transferred from outside institutions, whether it was northern, western, or eastern Missouri, nursing home, or other institutions. Those are the patients that were coming in with the multi-drug resistant organisms. Those are the ones that we identified and said, hey, it's not us. We're going to treat the patients 100%. But we did not cause the hiccup in the data. That to me is a win, and that's a way that we've monitored as to whether or not we're causing harm or we're doing good for the organisms and the antibiotics that we're using. Diff rates. So we started looking at Clostridium difficile rates, not only in looking at the protocol and how we use it, but we also got this fancy PCR machine that tells us whether or not it's positive very quickly or if it's negative very quickly. So it also tells us whether or not we're dealing with the hypervirulent strain, the NAP1 BI027, whichever you'd like to call it, the hypervirulent strain that's out there. So we can identify what our strains are. And as you can see, our testing has actually gone up. Why has it gone up? Because we have this new fancy piece of equipment that does it really quick. We look at inpatients. We look at outpatients. And if you look, our rate of C. diff from 2015 to 2016 is at 14.9%. National rates are at about 20 to 30%. Once again, I think we're doing a good job with our Clostridium difficile rates in keeping those numbers down. Robin, you're going to be speaking about that later. So it is one of the things in the monitoring that we've done and able to pull this data to show that the antimicrobial stewardship is being effective and is working appropriately. Last we have is Poundage. So how much do we actually use? So when I first started this program, I looked at 6 antimicrobial agents. Now I'm up to all of these that are listed. And the different colors, the yellow is what we've had a decreased use, and the blue is we've had an increased use. So looking, it's pretty much all over the board. As you can also see on the right, you have patient days. So our patient days have gone up from when we first started this in fiscal year 10. And then you have different bars that do have numbers and that don't have numbers that are clear. That's either when I added them to the monitoring that we did or when they came onto market. So in looking at newer antibiotics and antimicrobial agents, I'm having to shift and re-look at different areas that we're focusing on. Are we using a whole bunch of carbapenems? According to this last year, we went down. Are we using a whole bunch of piperacillin and tazobactam? According to this last year, we went up. Are we using a lot of IV posaconazole, a lot of ambisome? These are some of the ways that I actually track as to how the antimicrobial stewardship is. I had made the reference that there's a balloon. So if we're using a lot of linezolid and I try and squeeze the linezolid use, daptomycin may pop up or vancomycin may pop up. But at some point in time, the MRSA coverage is going to be out there. These are the numbers that we have in there from May of this past year. I didn't quite make the fiscal year turn by the end of June. So it's 1 month short in looking at it. This concludes the aspect of my presentation. I would like to thank Dr. Christy Cooper, Dr. Steve Witt, Dr. Ilboudo, and then Dr. Salzer for all the help that they've given me in implementing this program and the support that they've given me. And with that, thank you very much.
So to jump right into my topic. So when I came on board about a year ago, Joe has been doing a great work at the University Hospital, but I felt that some of the pediatric patients, especially at the Women's and Children's Hospital, were being left out, that the majority of the intervention seems to be focused on cost. And so I wanted to look at more of the clinical aspect. What are the complications that we're seeing in our patients? What are readmissions rate? And how can I have a more pediatric focus take on the stewardship work that was being done at our institution? So I have no disclosures, and basically I went through all the steps that are listed in the recommended guideline by the CDC as to when you were to start a new program, what would you do? Even though we have something existing, I wanted to create something that was very pediatric focused. So leadership commitment. Before coming on board, I gave a ground round during my interview process where I presented what my proposal was going to be. I talked about the presidential initiative, and I talked about the upcoming regulation. So having that discussion up front, people were aware of what was coming, and so it created more awareness and more support for what I wanted to do. So I was able to buy some time towards stewardship in my contract starting. And once I started, I sat down with the key stakeholders, so the NICUs, the PQ attendings, the oncologists, the pulmonologists, to see what would their needs be, how can a program help them in their daily clinical activities, again, very pediatric focused. And also going through the process of monitoring to see if they have any questions, any reticencies, anything else that I could address before going on full on to implement the program. And so after taking all of that in place, we wrote a protocol that was then approved by our executive medical board, again, to legitimize our activities. So to avoid some of what Joe had faced before, where you had clinicians, questioning your involvement in the patients and basically questioning the autonomy, which is not the point of the program, but a lot of questions will come up about autonomy and the physicians being able to do what they need to do without us necessarily getting involved. So having that backbone or that backup was really essential and really key for me. So the accountability that I talk about, so a lot of literature out there said that you really need to have physician leaders, so people who understand the prescribers and where they're coming from to help lead the stewardship program, even though we really need pharmacists as well. So I feel like it really has to be an integrated effort. And from the pediatric standpoint, we really didn't have that pediatric leadership that I was looking for. So I appointed myself to do that. And again, to increase more physician involvement in the stewardship activities that were going on already. As far as the drug expertise, again, Joe has been great, but he's so busy with the university hospital that never see him at the women's and children's or rounding on our patients. And so what we get oftentimes is a phone call as to why are you using so much daptomycin or linezolid. So I really wanted to have our pharmacist on site having more say into what goes on with the stewardship. So I sat down and I met with our two pharmacists and went through what their concerns were, what the needs that they see were, so that we can come up with the best intervention and the best program possible. And since getting them involved on board, I feel like they feel more empowered to make recommendations or suggestions during rounds, because they review all antimicrobials or all medications on every pediatric patients already at the hospital. And so this was adding more support for them to make certain recommendations during rounds without me necessarily being involved. Then the actions that we decided to work on was expand the list of monitored drugs that Joe already has, some of them being the beta-lactam, beta-lactamase combinations, some of them being the fluoroquinolones that are not necessarily the empiric or the best choice for otherwise healthy pediatric patients, which again is a different population than what he's dealing with at the university hospital. Then we also expanded the antivirals that we wanted to monitor, and then we created a restricted category. When I first mentioned the word restricted, everybody told me this is not gonna work, nobody's gonna let you do that, this is not the way that it works here. And Joe said, I've tried twice in the past and it was shut down and nobody allowed me to do this. And I said, well, okay, let's see, we'll see. So again, it really helped to have the NICU, the PICU, the pulmonologist, the oncologist on board to say, hey, this is what I want to do. Do you have any problems with it? Would you have any suggestions? What are your concerns about doing this? And really hearing from them gave me that support that I was able to then get approval. So the restricted list included drugs that have a potential for negative impact on resistance patterns, drugs that have complex use, either with the dosing schedule or they have multiple drug interactions, drugs that have high risk for toxicity, and drugs that have limited or unique indication and cost. A lot of the newer agents that we have are approved for certain indications in the adult population, but oftentimes they lack dosaging or specific use in pediatric population. So I wanted to focus on those drugs and restrict them at the front end so that people really thought about what they were using. The other reason why I wanted to have a restricted list is because we do have providers that go across the different institutions, especially our surgeons, and I've seen that they oftentimes, especially the trainees, they oftentimes will equate what they do at the university hospital straight to the pediatric patients. And I will give you an example of one such intervention that I'm currently working on. And then after we decided on what we're going to do, the next process is now how are we going to track it? How am I going to know where specifically the problems are that I need to work on, and how am I going to over time follow my interventions and whether or not they're working, similarly to what Joe is doing. But I wanted to do it in such a way that if Joe is not available or I'm not available, that someone else that we can train can look at that data and know what to do with it, so that it wasn't just restricted to one or two individuals. As we move forward and we have more patients involved in this program and more drugs involved in this program, to really make it a more streamlined process that anybody that we train can really do the work on a daily basis without either one of us, because we go on vacation and drugs, the costs go up and it feels like everything is falling apart. So I really wanted to create a process that could be streamlined and easily followed and a little more transparent from the prescriber standpoint, because some of the feedback that I received were that they seldom saw Joe, and so they really didn't know what they were doing, what the practices were, and whether they were one of our common offenders and how they could really overcome that. So I really wanted to create something that was more streamlined. So we started meeting between the pharmacist and our IT division to talk about how we're going to potentially do this. And so far, out of those meetings, we've created a restricted list that comes as a report through our email on a daily basis. So any pediatric patient who's been on a restricted antibiotics for the last 24 hours, we get a report through our email to see why the drugs were prescribed, what the patient had, what illnesses that these were done for, and then we could then reach out to the physicians to say to have these conversations about why they chose that specific agent. The next step is to work on an order message. So I wanted to take the burden off of the pharmacist to be the one saying, no, you can use it, especially after hours when Joe is not there or an ID specific trained pharmacist is not around, but really put that burden onto the prescribing providers. So when they order these drugs, there will be a message that show up asking them, do you have approval from the stewardship team? Does your patient have a history of a resistant organism as a reason why you want to use this drug? Does your patient have an allergy to recommended drugs as another reason why you may want to use another agent? Or is it an emergency situation? So then taking that burden off the pharmacist, we as the stewardship can then review that data 24 hours later to really see were these drugs ordered appropriately, to avoid the back and forth, because that was one of the issues that the PQ had brought up, was when I'm in an emergency or critical situation, I don't want the pharmacist to restrict my drugs, and I don't want to have that oversight necessarily from somebody who may not be necessarily trained into infectious disease specifically. So having that burden onto the providers, I felt, was a way to overcome that, so that they could have access and order the drugs, but there will be a message that we can follow up on to understand what the thought process was at the time of ordering. And the other thing that we are working on is to create an indication for all antimicrobials. And this stemmed from the antimicrobial usage reporting that we are now having to do, that some of the drugs listed in those modules are not drugs that we monitor, but as a way of helping whoever is going to be designated in reporting this data to have indications, because we realize that our ICD-10 codes may not reflect necessarily why these drugs were used, but if we can have an indication that the providers will then, they will have to tell us why they're using this agent, it can help us not only from the stewardship standpoint, but also from the reporting standpoint to understand what they were thinking at the time of ordering. And so this is, it's a little small, but this is, the top shows the restricted list and what comes. So I get a daily email on the patients, the location, the medication that was prescribed, whether it's still an active agent or a discontinued agent, and the dosage that was there. And over the last 3 weeks, we realized that there was a lot of carbapenem used in appendectomy cases. And when I talked to the surgeons, their take on it was, well, this is what we use at the university hospital, and so we just use a lower dose in our pediatric patients because this is what we do for all of our appendectomy cases. And so I looked at the power planes and realized that the power planes list every agent that can potentially ever be used for such an illness. And so what we are currently working on is to design a pediatric specific power plane. What also helped me in this process was having there was a recent article in the Journal of Pediatrics that talked about broad spectrum versus narrow spectrum antimicrobials for appendicitis cases in pediatric specific population, and they show that it really doesn't make a difference as far as complications or readmissions, but by using a broader agent, you are potentially exposing children to agents that they don't need, and you can potentially create resistance down the line. So those articles and those that evidence out there really helps with what I'm trying to do. Everybody has been pretty receptive when I do call them in the morning and say, hey, you may not want to use meropenem for your appendectomy. They've been really receptive, but sometimes what we run into is that it's a different resident every time, and so having a formal education to the residency programs, the surgery residency program, to have that formalized will be the next step that we look at. Other things that I've done is looking at our antibiograms. When I first started, I realized that there was a lot of outpatient parenteral antimicrobial usage for our osteoarticular patients. And the reason was because our women and children's antibiogram included the adults that come to our hospital. And so a lot of the oral agents that I was used to using in pediatrics had higher resistance listed on our antibiograms. So what we did was create an age-specific antibiogram. And looking at that, we realized that all of our pediatric patients over the age of 12, 100% of them that had an invasive MRSA had clindamycin susceptibility. And so I was able to change again the practices of our hospitals by saying, look, when we look at our pediatric specific data, this is an agent that we can use effectively. And that has created a lot of change. The next step that I'm looking for coming out with our new Antibiogram this year is not only age-specific but site-specific data. I get a lot of questions on UTIs and whether or not certain cephalosporins will be better than others, and so having site-specific data on top of the age-specific data can help us. But because our numbers are really low, we talk about how useful that could be, and so we are going to aggregate the data over 3 years to have the numbers to make it meaningful, and so that could be another aspect that we use as well. And I'm also working on an empiric recommendation list for our pediatric residents to use so that when they get that patient in the middle of the night, they know what to do with very common pediatric diseases such as community-acquired pneumonia, meningitis, or other disease processes that they see commonly. And then data tracking is something that's evolving. There is a certain antimicrobial solution that is pending release that we are going to use. But in the meantime, we are using existing reports to be able to generate the data and look at and also record for our interventions. And like I mentioned before, working on formal education of all prescribers at the time of hire, which is one of the CMS recommendations, but also on going through grant rounds and other formalized education processes. And the hope is that over time we can increase our FTE support both from the pharmacy standpoint and the medical standpoint to make this a better program overall. And I wanted to give a special thank to Dr. Jason Newland, who I was fortunate enough to train under at Children's Mercy, and every step that I've gone through so far that has been successful is because of him and his advice to me. I'm very thankful to Joe Cameron that coming on board, he was very supportive of what I wanted to do. Being a new faculty, sometimes there's that fear that I may not be accepted, but having his support really helps, as well as Brad Myers, our pharmacy director, Dr. Wheat, Dr. Fay, and Dr. Cooperstock from our department, who have been very supportive of my efforts. With that, I'm done. And do you guys have any questions for either one of us? Any questions?
I do have a specific question for Joe. This wasn't something you covered during your actual talk, but I noticed it on the slide. So we do extended infusion with Zosyn. One of our biggest problems is the incompatibility with vancomycin. Can you tell me about your results?
Absolutely. I missed that and apologize for that. So one of the biggest concerns that we had in doing an extended infusion with piperacillin and tazobactam is that according to the King Guide or Micromedics, it is incompatible or variable compatibility between vanc and Zosyn. One of the things that we did is we went to the lab and then did micro dilutions with all of our concentrations for vanc and Zosyn. We put them in the same test tube and we did spectroscopy. There is an older way to test the compatibility, but I think that device is located in the basement somewhere in some science building. So we just did liquid chromatography to determine whether or not they were compatible. It was discovered that they were compatible greater than 14 days. Everything was clear. We got the approval from the P&T committee to allow the compatibility between piperacillin, tazobactam, and vancomycin. And there have been reports and studies that have been published since that point in time that validate that as well.
So I have a question for Dr. Ilboudo. I work with older people, so I don't have a pediatric perspective at all. So I'm curious, how does it work when you're talking to family members about trying to reduce or narrow antimicrobials? Are they receptive? Do they get it? Or is it also a perspective of we have to pull out all the stops for our kids and our babies? How do you manage that?
So I do get a lot of those questions in the clinical, in the outpatient world. And basically the way that I approach families is to say, look, I'm trying to prevent something in the future from happening, and so using this drug as opposed to this other one will help in that endeavor, especially kids who do not need antibiotics. I explained to the parents, really, this could really be a viral infection based on the presentation, and so it is not to say that I'm not giving your child anything. So I talk a lot about supportive care, but also giving them a way out to say, if something changes, give me a call, and I'm more than happy to revisit the information again and take it a step further. But at this moment, I don't think that's necessary because of the potential of resistance in the future, and that's been very well received.